Okay. Let's try it. Okay, can you see that?
Yes, we can.
And let me make sure it's working. Yeah, it looks like they're all going through. Okay,
Yep, all looks good. Okay.
great.
Scott, why don't you so Scott's gonna be uh I don't know what the word what's the word difference between you and me, Scott? You're gonna start the meeting, but I'm going to moderate the meeting. Is that how it goes?
The major difference is I'm much older than you, I think. Other than that, you're
I
much smarter.
don't think so.
I
I don't think so, Scott.
no, I'm not quite sure. Latifa asked me to just do a brief blurb on the organization as a whole now that we've got these combined webinars, because just to give you Oscar and Brian a little background, we did these webinars for the last few years as part of the two consortiums, and I'll explain this in a little bit of detail, and I hope we have enough time. So G2MC, the Global Genomic Medicine Consortium, is involved in clinical implementation of genomic medicine. We have another consortium that's part of our overarching program called International 100K Cohorts Consortium, which is trying to bring together cohorts from around the world to do mainly discover and translation work. And both of those, this is where it gets confusing, are part of a nonprofit in the US called the 501c3 that is called Global Genomic Medicine Collaborative. So, and we thought it was a great idea when we did these webinars for a couple of years that we bring in the G2MC side to the webinars so that people that were interested in clinical implementation could also get to benefit from these. And so that's new. It's only started a few months ago. I think we've had, Grant, maybe one or two speakers, right, from the G2MC side. So you guys are a little bit of pioneers, and I'll do a 30-second just welcome everyone. Yes, you're in the right webinar. In case you put it on your calendar when it was called something else and it's called something different now, you're not in the wrong place. And then turn it over to Grant. And he will introduce you. Yeah. So that's the way, that's what Latif asked me to do, Grant. And I won't take up any time.
So Scott, you decide when we start, right? You will decide, and you'll be the first voice everybody will hear.
I will try to be the first voice, but people will join and chat a little. I'm not going to let it go very long. I mean, I think as soon as I see 4 or 5 people join, let's get started, because after introductions and everything else, we want to leave enough time for you guys for your presentations and any questions and answers. No one's not joining this to listen to Grant or I.
Yeah.
Not this one, at least. Maybe another one in the future.
I was going to have Oscar and Brian introduce themselves when their turn came up to speak.
That's a good idea.
Yeah, I do think, Grant, some overview of why you brought us together would be useful, because they're a little bit disparate talks, but I think I love the pairing. Actually, I think it's great.
I will definitely do that. So after Scott turns it over to me, I will do a quick introduction of myself, and then I will do a quick description of how this webinar came together.
Perfect.
And then from that, I'll say Oscar will go first. Oscar, take 15 to 20 minutes. I'm also going to tell people that we're going to have questions at the very end, and for them to enter those questions in the chat. So what will happen is we'll have Oscar do his 15 to 20, then we'll have Brian do your 15 to 20, and then whatever time we have left over, I will moderate the Q&A portion. I will read the chat questions and present them to you two to address. Does that make sense?
Sounds good.
Sure.
Okay. Excellent. I'm also going to quickly, as part of my introduction, I will share my screen. I wanted to tell the participants about the Family Health History flagship project at G2MC that I co-chair, and wanted to tell them a little bit about that. So I will do that screen share first after Scott turns it over to me.
I'll be quick, I promise.
Yeah, okay.
Oscar and Brian, where are you two located geographically?
I'm in Barcelona, in
Okay,
Spain.
I'm in Seattle in the United States.
great. And I know where you are, Grant, because I see it in the background.
Yeah. and Brian knows this background, right? Brian, how many years were you here?
Let's see, I did most of my schooling until graduate school there, and then came back for residency. So I grew up in Salt Lake City, went to high school about like an inch to Grant Wood's left, and then went to college at West High School, and then went to college at the University of Utah, which is right behind him, and then did graduate school at University of Pittsburgh and went back to Utah for residency. That's when I met Grant the first time. Although he might not remember very well.
You know, Brian, I did not know that you grew up here in Salt Lake. So that's interesting.
Yeah.
Brian, I grew up about 200 miles north in Idaho Falls.
Oh yeah, great. I know Idaho Falls well. I have a participant from Ghana right now.
Great. Thanks for joining. We'll start in just a minute after we get a few more people on.
And where are you now, Scott?
I'm in North Carolina today.
Okay.
Durham, the Triangle area. You're familiar with that? Yep.
Yeah, my sister's there.
Oh, okay. She at school, does she live there, or is she going to school at one of the universities?
She's a violin teacher at Duke.
Okay.
So, yeah.
Yeah, I'm about 5 miles away.
Okay, nice.
So Brian, your sister's the smart one in the family, huh?
She is.
Duke has a big football game coming up on Saturday against Notre Dame, and for the first time in decades, Duke is ranked in the top 25 too. So it might actually be a good game. But I just read that the ESPN College Game Day is coming to town to take everything over. So I think I'll sit at home and watch it on TV.
I've stopped following American football.
Yeah. It's a habit that's hard to break.
Brian, you're not a Utes fan then?
Sure.
Yeah, okay. You have to be now. Now they're doing well too.
Yeah.
Of course. We're saying no. Go ahead.
Go ahead, Grant. I'll start. We're at the top of the hour. We've got about 14 or 15 people on, and more will join. But welcome to those of you that have joined the Global Genomic Medicine Collaborative webinar. We used to have IHCC International 100K Cohort Consortium webinars. Now we've combined that with our sister organization, the Global Genomic Medicine Consortium, and they both are under the umbrella of the GGMC, and it's very, very good to have talks that are both covering the transit from early discovery to clinical implementation. So we're looking forward to that today. Our moderator today is going to be Grant Wood, who's on the steering committee of G2MC and also an advisor to the board of directors for the Global Genomic Medicine Collaborative. So, and I'm Scott Sunseth's director of the IHCC International 100K Cohort Consortium. Grant, I'm going to turn it over to you as moderator to introduce the speakers.
Thank you, Scott. And let me take just a few moments to do a quick introduction of myself and what I do with the Global Genomic Medicine Collaborative. So I, for the past 17 years, I had worked with a large healthcare system in the state of Utah called Intermountain Healthcare, and I worked with their Clinical Genomics Institute. And my role in that activity was to develop the computer applications that clinicians would use to manage genetic and genomic information and family health history information. So my role was to try to get a computer system that would capture genetic test result data and put that into the patient electronic health record, along with capturing family health history data and get that into the patient electronic health record. And after 17 years, we're still working on achieving those goals. So there's still a lot of work to be done in that area. Let me quickly tell you about the Family Health History Flagship Project within G2MC. I've been working with G2MC for about 8 years now, but for about almost 4 years now, I've been working as a co-lead of the Family Health History Flagship Project. And the idea behind this activity is that there are people around the world, G2MC is an international organization, that are looking to implement family health history programs within their countries. And so we gather together as a group to discuss different shared projects. We have different presentations to provide information for the members of this flagship group. We try to help each other with everybody's implementation desires that they might have in their own countries. We are embarking on a very aggressive shared project that will be launched next week at our G2MC has their annual conference. We'll be in Geneva, Switzerland for that conference. We'll be launching a very aggressive project within our group that goes through about 11 steps on how would one follow to do an implementation of family health history. If you are, I'm looking at this website right now. This is on the g2mc.org website, family health history section of that website. I recommend that you go there and see. We have a lot of content here and stuff that people can see. One thing, if you would like to get involved in that, you can click on this Get Involved link here, and it will take you to this part of the website, and you click Contact Us, and you get more information about this activity. Okay, I'll stop there, and let's launch into the program that we have for today. So I want to give you some quick background of this. About a year ago, I was at a conference and did a presentation on family history. And I met Oscar, who also did a presentation, and we had not met each other before then. He did a presentation that I had, the subject was something that was absolutely fascinating to me in the world of family history, because it wasn't your typical point of view. And Oscar will get into that, but he takes us all the way back to the evolutionary causes of genetic disorders that run through families. And so I thought that was absolutely fascinating. And then I said to him, we need to get you to do this presentation to a wider audience. It's taken us a year to get this done. But then in the meantime, I met Brian and found out more about his activity. And it was fascinating, his goal as to how can we look at our current knowledge of the genetic causes of cancer in families, and what can we do now to try to eliminate those from future generations. And so Brian has a very interesting perspective too. And I just thought it was a great combination to go all the way from the evolutionary causes to what we can do with today's scientific knowledge to maybe eliminate some of those genetic causes, more specifically in cancer. So what we'll do is I'm going to stop sharing, because we'll let Oscar go first, and we'll let him fire up his slides. And what we'll do is Oscar will introduce himself, to do his presentation. Then we'll pass it on to Brian. Brian will introduce himself and with his presentation. We will save our questions till the end. And of course, as always, if you could put those questions in the chat, and at such time as we get to that Q&A place, then I will pass on those questions to our two speakers and have them address them. So with that, I'll stop talking and turn it over to Oscar.
Thank you very much for the invitation, Grant. It's really a great pleasure and an honor to be here today giving this presentation. So my name is Oscar Lau. I am a principal investigator at the group of, an artificial intelligence mixed group that it's called Algorithms for Population Genomics. So my background is biology, but I also am an informatician, and I just set up my group in Barcelona at the Institute of Evolutionary Biology a couple of years ago. And with this, what I would like is to start the presentation, which has this fancy title. Let's see. And in this presentation, I will try, I don't know if I will succeed, but I will try to convince you that whenever you are talking about health and disease, taking into account evolution, it's also an interesting aspect. I would say it's a critical aspect. So I will start this presentation with this paradox. So if I ask you if you have ever had a dental caries, I'm pretty sure that 50% of the audience will raise his or her hands. This is a quite prevalent disease in modern countries, or in general, and we know that it can be quite impairing. So, I mean, I don't know if the people that have had one knows what it means to have a cavity and the associated problems. So the way how we solve this is usually going to the dentist. We sit in the chair, we start sweating because we know what is coming next. The dentist asks us to open the mouth, and then it comes a half an hour of blurriness in our brain regarding to what's happening in our mouth. Okay, so one of the things that is very paradoxical, at least when I was studying biology, pissed me off a lot, was that thinking that if this was a prevalent disease, this is not the only one. I mean, you can list many of them that are nowadays very, very prevalent. And I stress that nowadays, what happened in the past? Did our ancestors have the same prevalence? How did they solve the problem? Because there was not such a medical treatment as we have today. And what it's really shocking is that when you start looking the prevalences of caries in different for different periods, time periods, and regions, you see that the prevalence of dental caries is quite low. So what's going on? What's happening? Why we are having such a huge amount of dental caries nowadays that was not before? This goes with the concept that I will go around with this presentation of maladaptation. So when we are in an environment, we biologically adapt ourselves. If the environment changes, then what we had before, it's not adapting anymore to this new environment. And then what has to happen is that either we change the environment back to how it was, or we have to evolve towards this new environment. And evolution can be either biological one or cultural one. We thought about changes in environment. We have to think back into what means being human. So current theories or current models suggest that humans evolved in Africa, and then they spread out of Africa around 100,000 years ago, then conquered the whole world in a relatively short amount of time. Following this principle that I said before of maladaptation, what happens is that when they went to those new environments, they found new environments, and then they have to be adapted to those ones. And the first way to do this was biologically. So we can find in our genome evidence, fingerprints of adaptation related to some of these new environments, new situations that we face as a species. In addition to that, when our ancestors went out of Africa, they met other almost species that were living in Eurasia. principally in Eurasia, and also probably also in Oceania. And well, they basically mix with them. So you will know them as Neanderthals or Denisovans. This is what they happen. So they mix with them, not in this way. So this is a kind of a weird depiction of what a Neanderthal looks like. This is more what a Neanderthal we think would have looked like. So you see it's quite similar to what modern anatomical modern humans are. And this is for a male, and this would be for a female. So they would I mean, a mixture between the different populations, archaic populations, would be feasible. What we know is that in our genome, people that it's mostly out of Africa, but also within Africa, in a much more amount of percentage, we have seen fingerprints also of this genetic admixture. And this genetic admixture provides us two type of different outcomes. The first one is that we incorporated in our genome genetic variants from those archaic populations that were already adapted to the environment where they were living. Second one is that those other variants that we incorporated also predispose us to particular for particular phenotypes and diseases, such as, I don't know, smoking, obesity, depression, and so on and so forth. Okay. So, but why do we have dental caries? What has this to do with the demographic history that I have been explaining? Well, in fact, it has to be relatively a lot and not so much, in fact. If we think in evolutionary terms, the change that we have faced during the last 200 years, and particularly almost during the last 100 years, so from the Neolithic onwards, it's huge in evolutionary terms. And this means that there are a lot of possibilities, that there are a lot of phenotypes for which we were before, as hunter-gatherers, we were adapted, and nowadays we are misadapted. Okay? So we are going too fast and in a too short time. And this is even becoming more and more faster. So right now we shouldn't be here. From a biological point of view, we shouldn't be here sitting and just listen to me, but probably we should be hunting in a forest, or being hunted by an animal in a forest. Okay. So there are a lot of phenotypes nowadays that we call diseases that, or they are related to diseases that are basically has been associated or suggested to be result of this sharp change in the environment from the past to the present. Okay, so from an evolutionary point of view, that is the kind of concept that I want you to keep on. Okay. So the point is that to test those hypotheses are those phenotypes under this maladaptation. We should check out the genetics of this phenotype, so where we can look for fingerprints of the evidence of positive selection or changes in a positive selection. The problem is that obviously the phenotype that we observe, complex phenotypes, are the mixture between genotypes and environment. And here you can put whatever you want, of course. So figuring out how this phenotype, that could be, for example, cavities, is has been under selective pressures in the past, but now is nowadays under selective pressures, implies understanding the genotypes or the genetic background of this phenotype. And nowadays we have a way to approach this. I mean, it's not a perfect one, and there are a lot of complaints about how it works. That it would be the GWAS, genome-wide association study, in which you can do a scan in the genome, trying to find associations between a phenotype, the genetic variation present in a population. Okay? So with those markers, then what we could try to do is analyze it from an evolutionary or genetic population point of view in order to make evolutionary inferences. Okay? I will try to present in the next 7 minutes two different examples of things that we have done in my group, or we are still doing in my group. The first case, it's ADHD. So basically nowadays we know that ADHD, it's an impairing condition, or can be an impairing condition. And yet the prevalence in the population, it's quite large. And the heritability of this trait, it's also quite large. So how can it be that from an evolutionary point of view, we still have this huge amount of this phenotype when we, as I said before, it has some detrimental fitness. Well, The thing is that what has been proposed is that in this phenotype, maybe nowadays it's not it's impairing, but maybe in the past it was a phenotype that was fully supported by the environment where our ancestors were living. I mean, if you broadly divide this phenotype into three major components, what we can think is that in the past environment, being a hypervigilant, impulsive, or having high motor activity, that is one of the three components, since in ADHD was a good feature towards the survival of the individual carrying those features. Nowadays, what we are trying to do is having more in the others, in the opposite. And then those features that before were good, nowadays are bad. Based on this type of thinking, there have been different hypotheses proposed trying to explain the high prevalence of this phenotype in current human population. What we did in 2020 was to analyze the genetic trajectory over time of genetic variants that has been associated to this trait. And we could do this because there is a huge, and this is something that is very interesting, and I think for the medical community in particular, there's a huge amount of genomes retrieved from different ancient times. Okay, so those genomes, for example, we focus in Europe because the type of data we had was from European individuals, ancestral individuals. So what we can see is that it ranges from 10,000 to 40,000 years ago. But the data set, this is completely outdated. If you go to current data sets, they are much broader, and they almost reach from the present to very, very old times, so 50,000, something like that. And they cover also Eurasia and also some of the African continent, basically because of the way how the DNA quality is preserved in the African environment is lower. Okay. So what we saw is that if this is the frequency of the alleles that are in the y-axis of the alleles that are associated to ADHD in current populations, and in the x-axis we have the time of the sample. What we see is that there is a decay, constant decay, and it is independent of which data set we use, and a decay in the frequency of those alleles over time. So in the present, we are tending to have less of those alleles than we had in the past. This observation would go supporting the hypothesis that in the past maybe phenotype was under positive selection, and nowadays it's under purifying selection. So it's detrimental to have those alleles in our genome. In fact, we were able to model the selective pressures in this phenotype using also ancient DNA genomes. And what we saw again, I mean, this is a distribution of the selection coefficients. The negative ones implies that there is a selection going against this phenotype, and this is again what we observe. So it's again reassuring the hypothesis that before was good, nowadays is not good. What happens is if you try now to incorporate in the equation the Neanderthal genome, so those alleles that have been introgressed from Neanderthals, we see that in fact, based on the association that we have of alleles related to ADHD, we would expect to have much more Neanderthal alleles that we have nowadays. So this means that the Neanderthal alleles that have been introgressed from ADHD alleles have been cleaned from our genome, again supporting the hypothesis that what before was good, nowadays it's not good anymore. So for the case 2, I would like also to show a bit of what happens when you start talking about pharmacogenes. This is a project that is ongoing for a couple of years, and the idea is that when you take a drug, you can have an adverse drug reaction. Those adverse drug reactions are impairing, and it can be very, very, very tough. In the past, it's unlikely to have this because it's unlikely that you could have 10,000 years ago an aspirin, although you could take the principle from obviously from the tree. What we wonder is what happens when you pick up markers, genetic markers that has been associated to adverse drug reaction events. And with this in mind, what we divide with this device, it's a food pipeline with particularly, this is the work of Kari Phyllis and Sonia. where we were able to retrieve from that different databases the genomic information of SNPs, genetic variants that have been associated to adverse drug reaction events for different types of drugs and different types of systems. The idea is that with this, after doing this extraction, when we analyze which are the different SNPs that we recover, genetic variants, we see that many of them are related to functional changes. So this is very good because in this case we have kind of a causativity between the drug adverse drug reaction event and the biology. In the previous case, we only have the results from GWAS. And we applied, basically, we retrieved data from the human genome, from different populations, and we just selected those variants that have been associated with adverse drug reaction event, and just plotted all of them, condensed this information in this biplot. Okay, so this basically, each dot would be one individual, and we have just marked the different continental, subcontinental rotations, clusters of individuals. And what it's interesting to see, it's in the first dimension, we separate African versus non-African populations. This is a constant. So if you take the full genome and you do this type of analysis, you will see that the first division is African versus non-African, and this reflects this out of Africa diaspora that I have explained before. But it was interesting to notice is that this cloud here that correspond to East Asian individuals were very different from the other Eurasian populations. This was kind of surprising because this is not what you expect to see in the rest of the genome. So you take the whole genome, you will see this gap here. It's a genetic continuum. When you start analyzing, conducting an analysis of how many alleles, risk alleles, do you have in each of for each adverse drug reaction event drug, you have how many alleles do you have each individual from one panel that we have, worldwide panel. What we observe is that in this area, so East Asian and Central Asia area, the number of alleles associated to adverse drug reaction events is lower than what we observe out of this area. So the rest of the world has a has higher amount of adverse drug reaction event alleles compared to this East Asian population. And this is something that it's again shocking because this is not what one would expect. Why there should be a division of those adverse drug reaction event alleles in East Asia. And in any case, what this would mean in terms of adverse drug reaction event strategies. What is also very interesting is that when you pick now subdivide these adverse drug reaction events alleles based on which are the type of phenotype that they are trying to target. So for example, we would have cardiovascular drugs or antimicrobial drugs, anesthetic drugs, and so on. What we see is that between the different continental clusters or subcontinental clusters, you observe differences also in some cases for one of the continents, for some cases in another continent. Overall, would claim to a lower amount in East Asians, but this heterogeneity, it's also very interesting because it means that depending on which genetic background you are want to work, you will have to decide which type of adverse, just a priori, which type of adverse drug reaction event could happen in more likely, okay? So just to finish, because I'm almost out of time, what I would try to convince you, I don't know if I succeed, is that evolution is something that goes beyond the biology and can also be incorporated as a tool in medicine, just to first understand the genetic relationships between individuals, so to establish a much stronger, a much robust pedigrees by analyzing the DNA of those individuals and looking for the real exchange of DNA between individuals, or also by taking into account the evolutionary terms and evolutionary concepts and try to understand the disease in a much more biological way. What I believe is that doing this second step will allow medical doctors to devise new strategies that maybe are less strong or less or are more appropriate for the patients, in addition to what it's done by classical medicine. So thank you very much for your attention. Those are projects that have been involved in all this type of research that I have introduced to you. Thank you much for your attention.
Great. I think it's my turn now. Thanks so much, Oscar. That was wonderful. So hopefully everyone can see my slides. And I'm going to take this in a little bit different direction, but still thinking about family history and evolutionary history. Oscar is talking about some deep evolutionary history. I'm going to talk about very, very recent genetic history. And so we're going to talk about the ConnectMyVariant project and about how we can use all of the tools we have now from genetics and genealogy and even social media to be able to help prevent hereditary cancer. So first, what is hereditary cancer? This should be a review for everyone here, I hope. We know about 20 genes that are associated with hereditary cancer risk. The top bullet point there is genes that cause increased breast, ovarian, and probably prostate cancer risk. Next set of genes causes a syndrome called Lynch syndrome that causes increased colon and endometrial cancer risk. Those are the most common hereditary cancer diseases, but there's a whole lot of others. There's a whole lot of others that have specific risk phenotypes and cause specific risk for different patterns of cancer. Now, this is not all of cancer. There is a lot more cancer. So most cancer is sporadic, caused by random mutations. Some cancer is familial. That some of this may be genetic, but has a low risk, or maybe clusters of family because of polygenic risk or because of environmental factors. But about 5 to 10% is hereditary. Most of this is preventable in countries that have developed surgery and radiology and gastroenterology systems. By colonoscopies, mammograms, breast MRIs, and surgery, you can prevent about 90% of hereditary cancer. So this is what a family can look like with hereditary cancer syndrome. This is a family with a PALB2 variant, and the green individuals are people with a PALB2 variant. The ones that have red have breast cancer. There's some colon cancer mixed in there as well, and some uterine cancer. There's a little bit of ovarian cancer, and several other cancers as well. Breast cancer, you can see, is the most common cancer here, that's known to be associated with pathogenic variants in the PALB2 gene. So every instance of hereditary cancer prevention depends on someone knowing their family history. And I think this is why Grant would like this presentation, wanted me to come talk, because it's really, really important to know family history. Now, there's two ways you can prevent hereditary cancer with family history. One of them is, and this is what happens most often right now, is that someone knows about their history of cancer, knows about their family history of cancer, and says, I should get genetic testing because I have this strong family history of cancer, and I want to see if my cancer or my family history of cancer is due to something hereditary. The other way is, let's say this person gets tested and they find out they have a pathogenic variant in one of those genes. Then they can tell all their other relatives. Those other relatives don't necessarily need to know the whole family history of cancer. They just need to know, the most important information for them to know is what that pathogenic variant is. So this person's siblings, children, and parents are each going to have 50% chance of having that pathogenic variant. Their nieces and nephews are going to have 25% chance of having it. Their cousins are going to have 12.5% chance of having it. But if this group tests positive, then all of a sudden their kids have 50%. So you can modify the risk depending on who has known risk and how closely you are related to those individuals. And in general, at least in the United States, once someone has more than about a 5 to 10% chance of having a pathogenic variant, it makes sense for them to get genetic testing. About 1% of the whole population. So you could do population screening, and about 1 to 2%, depending on which paper you're reading, of individuals have a pathogenic mutation that causes hereditary cancers. So knowing the family history allows you to increase the sensitivity of the diagnostic testing, or increase the positive predictive value of the diagnostic testing by 20-fold or 50-fold even. So how well do we do at preventing cancer? Right now, this data is from the United States. In the United States, we do about 200,000 tests each year to detect people with high cancer risk, 80 to 90% of the people with a positive result already have cancer. So think about that. We have the technology to prevent all hereditary cancer. We have the technology to identify people who have hereditary cancer risk, but at least in the United States, we don't do very well. In the United States, isn't an extreme outlier. I think we don't do quite as well as places like Australia and New Zealand, in the UK, but even there, most of the people who get diagnosed with hereditary cancer already have who have a positive test already have cancer. So this is supposed to happen, and this is supposed to happen. This is the recommendation that's been shown over and over again in literature from across the world. People are supposed to get the genetic test results. Their physician or a genetic counselor or some other health professional is supposed to tell them about that result. They're supposed to talk to their family members. Half of those people are going to test positive, half are going to test negative, and that's going to lead to prevention. Now, the challenge is that most health systems are really good at doing this, but many health systems aren't set up to do family history and to do family communication effectively. Most health systems are geared towards treating the individual, and only in a few countries do you have health systems that are designed with families in mind. This is a figure from a supplemental table from a paper by Ken Offit and Melissa Frey and their group, and they found that when with modeling, if cascade testing were effective and all cases that look like all cancers that look like hereditary cancer were effective, then people would be reaching out to first-degree relatives, second-degree relatives, and eventually third-degree relatives wouldn't find out about it. And if we could do that effectively, then we could prevent all hereditary cancer in any community within 10 years, which is just phenomenal. So we test all the cancers that look like that have the phenotypes of hereditary cancer, and then do a perfect family outreach. We could prevent hereditary cancer in 10 years. Now, no one's doing this effectively. And so what we thought we could do, what we realized would be an effective way to do this, if two people have the same pathogenic variant, so let's say these two people over here, then the haplotype analysis shows that about 90% of the time they have a common ancestor. These pathogenic variants don't happen all that often in the population, and there's not an extreme selective pressure. Oscar might have showed that the selective pressure is maybe greater now than it was in the past because we're living longer, because grandparents are more important, and so people are able to get cancer where 10,000 years ago, then individuals may not have lived long enough to develop cancer, even if they had hereditary cancer predisposition. These variants are rare enough that it does suggest there was at least some selective pressure against these variants over evolutionary history. But it may not have been very strong if you go back 10 to 20,000 years. And certainly if you go back 2,000 or 3,000 years, we see some of these variants many of these variants look like they're 700. Well, many variants look like they're 700 to 1,000 years, the ones we see more often, but many variants look like they're only 200 or 300 years old. And in 200 or 300 years old, that's far enough back that we have genealogical history, and we can potentially identify individuals who had these pathogenic variants. So I looked for people who had collections of big families, and Heather Hampel at the Ohio State University, Mary Claire King were the two people I found. Most of these are from Mary Claire King, but she found that when she connected second cousins here, then this is the number of additional relatives that were genotypes, and this is the number of relatives per positive variant. There's a huge variance in how big families are, and so sometimes you only get a few people who test positive, and sometimes you get a lot of people who test positive with second cousins. With third cousins, there's even more variance, but there's also even more relatives tested positive per variant. So if you connect second cousins, you can get a median of 12 or 13 people who test positive for the variant. If you connect third cousins, then that goes up to 20 to 40 people who test positive. So what happens when you connect random people who have the same variant? Now, they don't know how the pattern with two people, you find out immediately they're second or third cousins because they talk to each other and they compare who their grandparents were. We did a study to see what happens when we connect random individuals, and we offer them ancestry DNA testing. We offer them genealogy assistance. We talk to them about posting on some of the Facebook groups that talk about BRCA1 and PALB2 and Lynch syndrome. And we found that when we connect random people who have the same variant, then it increases their motivation to do this family outreach. It lets them realize they can do family outreach beyond their immediate relatives to potentially to their cousins. It helps them think about which of their grandparents might have had it and start to talk to the cousins on that side of the family. And we saw a 2.5-fold increase in family outreach among people who are just because we're connecting them up and having them talk to each other about their family outreach and where their variant came from. So when we learned this, that study that I was talking about morphed into a public health initiative and then a nonprofit organization. So we've been doing this for about 4 years now, and initially started as a research study. Now we've got a 501c3 nonprofit organization in the United States to be able to do this. And our goal is to prevent hereditary cancer. And our goal is really to prevent hereditary cancer, not just in the United States, but on a global scale. And I'll talk about a little bit more about it in the future. So this is what we do. We have a central database of people who they sign up and they say, I want to meet other people with my specific variant. When two people sign up with the same variant, we introduce them to each other using email and first name, and then let them share more family information, more personal information on their own time through their whatever mechanism they want to do that. And then we encourage them to do that. And we've seen families, variant groups connect across multiple states, time zones, continents. One of our variant groups has people. It was like this called people in every time zone. We had people in Australia, New Zealand, the UK, and in 2 time zones in the United States. And we have people who have connected with relatives in Mexico. We have families that are connecting in Trinidad and Tobago, and like I said, Australia, New Zealand, multiple parts of the country. Right now, our website's available in Spanish, English, and Chinese. Thanks to Evelyn Fang, who's on the call. So thank you, Evelyn. And so we match motivated families with each other. We also try to match patients with appropriate cancer testing with doctors. We don't do genetic testing. We let people get clinical genetic testing wherever they are and where that's what clinical genetic testing makes sense for them wherever they're at, so they can get follow-on treatments and prevention based on that. And this is just a slide that kind of shows all the different things we do. We use some genetics education workshops. We have materials on our website and a monthly newsletter. And we have these very specific family reunions and big pedigree stuff. And we have partnerships with the Bowie Center for Family History and Genealogy, who does free genealogy work for us. And so we're really trying lots of different ways to help with this, whatever we can do to help people with their family outreach. And I'm coming back to this pedigree because you saw this pedigree at first, and when you saw it, I bet you thought that I pulled this from a scientific paper or that I put this together myself. But actually, this is a pedigree that was entirely assembled by a patient and 12 other people. All of the people with stars by them, those are individuals that this person with ConnectMyVariant reached out to. And so this was put together by a patient doing their own family history work and working together with a dozen other patients who had this PALB2. So this is a patient generated pedigree. And I asked them if I could use this and share it in presentations like this. Actually, I knew they put together this pedigree and asked if I could share it. And they said, absolutely, because she wants others to see what one individual can do. And a group of patients can do working together to help prevent hereditary cancer. So there's 2 individuals here on this side, and I just actually spoke with them like 3 weeks ago. And these are 2 second cousins, and it was a really wonderful conversation because what they were doing is exactly what we were hoping that people will do. They knew which of their great grandparents had the variant, and so they were going through systematically through each of their cousins and second cousins, saying, "How do we talk to this person? Is this person getting tested yet? This person tested negative, so their kids don't have to worry about it. This person tested positive. Some of their kids know, some of their kids don't know. This cousin, who's more closely related to this cousin, who should talk to them?" So they are so families like this are the driving force. It's gonna help. It's gonna make it possible to prevent all hereditary cancer. This is what we're looking at now. So in many places where genetic testing is available, a small portion of people have already a small portion of cancer patients are already tested. And the data shows that for each cancer patient that's tested right now in a country that doesn't have an effective mechanism for family outreach, then about for each person that gets tested, about 50% of their relatives already get testing. And then there's a large number of relatives that could be tested if these individuals just have help reaching out to their first and secondary relatives. And then with the large families and connecting distant relatives to find common ancestors, we could detect almost all individuals who have hereditary cancer. Right now, there's still a lot of still families that can't be identified, but this gray box is going to get smaller and smaller as genetic testing becomes more and more common. So really, if we use the technology that's available, that exists, then we could prevent all hereditary cancer in places that have genetic testing available in the medical system within 10 years. So that's our goal. So that's what I wanted to share with you, that this research project turned into a nonprofit organization to prevent all hereditary cancer. And we can do this, and we hope that this organization helps. Let me go. Okay, here's our board of directors. This is Emily Maloof, Chandler Lewis, Winora Johnson, Leanne Sedana, and Carol Eldridge. If you want to find our website, you're welcome to go there. If you know someone with hereditary cancer risk, you can tell them to sign up, and we can find other people who have their pathogenic variants. And then this was the initial research study was funded by the Broden Beatty Institute, and the transition to a nonprofit business was done by the UW CoMotion. And of course, a lot of people were involved in this. And I also especially want to thank Evelyn Fang, who's on the call, and who's been one of these many volunteers who have helped with ConnectMyVariant. So thank you. Again, we're looking for partnerships locally and globally. And if you want to jumpstart the extended family outreach in your community or your organization, then please send me an email. And that's all. Thanks so much.
All right, fantastic. Thank you very much for both speakers. And we do have some time for some Q&A, and we have some questions already in the chat that I will get to. I'm going to start with this. There's some questions for Brian first, and then I'll get to some questions for Oscar. So for Brian, how do you see genetic testing being possible in third world countries? So you have this activity, ConnectMyVariant, which involves genetic testing. How do you see that being supported in third world countries where genetic testing is a little bit more difficult?
Yeah, it really depends on the family, and it really depends on the specific situation. So one of our families, some of the people in the family are in the United States, and others are in Trinidad and Tobago. And that's an example where it's actually been really remarkable to see how the family itself has worked with each other to try to get genetic testing. And so they've done things like having their relatives in Trinidad. Well, there has been genetic testing in both places, but sometimes it's easier to get to the genetic testing in Trinidad, and sometimes it's easier for the relative in the United States to send a genetic testing kit to Trinidad, have it sent back to the United States, and then get tested and send the results back. So one of the wonderful things about this is that families work together to be able to do hereditary cancer prevention. The genetic testing is becoming, at least clinical genetic testing, the costs are going down. It's becoming more and more widely available globally. And so I see this as something that this is like the most cost-effective, one of the most cost-effective things that can possibly be done in terms of genetic testing. The prenatal screening may be another one for specific disease like for cystic fibrosis and for phenylketonuria. But between prenatal testing and this family outreach for hereditary cancer, these are kind of the entry level for genetic testing, for cost-effective medical genetic testing. So there's some places where it may not be available, but I think it's going to be available globally within the next 5 or 10 years, with the cost of genetic testing decreasing.
Yeah, and for those countries where genetic testing is difficult to access, I would suggest starting with a family, doing a family health history. Just start there. Anyway, next question is, what is your feeling about universal testing for certain populations with high levels of hereditary cancer variants for example, Ashkenazi.
Yeah. So there are specific variants that are common in Ashkenazi Jewish populations, and the overall prevalence of hereditary cancer is about 2.5 to 3%, which is about 1% higher than it is in kind of any other population you look at. So it's a little bit higher. And in a wealthy country that wants to do universal genetic testing, that can absolutely make sense. But every way that I've looked at it, then universal genetic testing is more expensive than the family outreach, if you can get the family outreach to be effective. So there are certain places where it may make sense financially and from a public health perspective to do that. But for most places, it's going to be more cost effective to do good family health histories and a really effective cascade outreach. So, and that's true even for Ashkenazi Jewish families.
Yeah, so I think that question around doing population-based testing, it really gets down to you're doing family-based testing anyway, right? So you're really going to start with the families within that population first, and that could drive maybe a larger population activity.
That absolutely makes sense. And if you're doing, it makes sense to start with the families. If you're doing the whole population, it's sometimes difficult to get individuals. So even if you're doing population screening, you still want an effective family cascade outreach plan to be able to have a higher chance of getting those individuals that are highest risk. Yeah.
So Brian, I'm going to ask you one more question, and then I have some questions for Oscar. So a person wants to know, do you have more females than males in your networks?
Yeah, absolutely. It's about 90% women that are signed up for this right now. Both are equally effective at family outreach. And then the other thing that's really interesting is sometimes we see, Deb Owen's research showed that females are more likely to be family communicators, family health communicators. And so sometimes we see people who don't have the hereditary cancer risk variant, who are the people driving the outreach. Someone who tested negative, my sister tested negative, somebody's sister tested negative, and they're the one doing it. The sister tested positive, and they tested negative, and so they're doing it. Or there's one person who's very, very active. Her daughter had breast cancer, her husband had prostate cancer, the variant's coming from her husband's family, and she's the one doing the family outreach there. So that's a new take on it. This is a family. This is something the family should be involved in, not just a specific patient. But yeah, we see about 90% women.
Yeah, that's been my experience with family health history and all the years that I've been focusing on family health history. And that is when we encourage people to collect their family history, and we encourage males to participate as much as females, but it's the mothers and the grandmothers that have all of this family knowledge, and we always suggest that if you don't know about your family, and talk to a mother or a grandmother or an aunt, they will usually have that information, and it's so wonderful that they take the lead on this, because otherwise probably wouldn't get done as much. Oscar, a couple of questions I have for you. So when you first were talking about the evolutionary aspects of ADHD, my thought was, now, do you feel like that ADHD variant was a mutation, or did it start, or did that particular variant start and then it, because of the environment, it got changed?
So yeah, I have made the story very simple, but it's, of course, it's much more complex. In fact, ADHD is a complex phenotype, so it involves a huge amount of genetic variants. So this is the first issue. The second is that there is a pleiotropy, so ADHD variants are involved in other phenotypes. And those other phenotypes can also have their own agenda, to say it in evolutionary terms. So they could be also under positive or negative selection. And this is something that right now it's not clear, because all those phenotypes are intermingled. So they interchange, they exchange genetic variants, and they overlap even in the phenotype spectrum. So I am not sure, or I cannot assure that the genetic variants that are associated to HDHD appear and they became neutral, and at a certain moment they became, oh, like, look, this phenotype, it's really important for the survival, and or the other way around. Or if they were already associated to a particular other phenotype, and then as a consequence of that other phenotype, they start increasing in frequency, and therefore increase also ADHD. So this is something right now we cannot really test, to be honest.
Another question that I had for is, you had a slide with map of the world, and there seemed like there was very distinctive differences between regions as to which genetic variants were more prevalent. And it almost feels like we aren't fully aware of those very radical differences. And a lot of times when we, and I know that we do this in the family health history world, we kind of think that the application of family histories is kind of genetic no matter where you live in the world. But in reality, there should be focuses on very specific genetic mutations in different regions of the world. And I don't know that we appreciate that as much as we should. What are your thoughts on that?
I totally agree with you. I mean, so first of all, I think that even the pedigree structure can be different in different parts of the world. So there are regions in the world that they enhance the inbreeding, for example, nephews with aunts or with uncles mating, and this is a cultural thing. So this would be a first level, and this of course has implications on the genetic variants that you will have in that population and their frequency. I mean, a highly inbreed population will tend to have a higher rare variance in the rest of the world frequency. And this is something we have to take into account. So whenever you are, and that's another point that it's very relevant, and it goes also with the Ashkenazi, but also with the Roma. So any population where it's kind of has had some kind of genetic barriers preventing it of changing a lot of genetic variation with other populations will tend to be particular. And this kind of information has to be taken into account with even when constructing the pedigrees, or we're taking into account the pedigrees, because it's not the same one situation or the other. Yeah.
And another question for you, Oscar. I was struck by, when I saw your presentation the first time, about there's very specific phenotypes that were developed, tens of thousands, 100,000 years ago, that were developed because it helped for the survival of that affected person. And I think as an example, if I recall, that sickle cell anemia was actually a phenotype that was a survival one in some odd way, because if you have sickle cell, you are less affected by
Malaria.
Malaria. Yeah, thank you. Malaria. So can you talk about that quickly?
Yeah, I mean, from an evolutionary point of view, nothing is good or bad. So evolution, it's opportunistic, and it takes what it takes at the moment when it's interesting. So we are basically the byproduct of things that probably nowadays we would say, look, why do I have only 2 hands and not 4 arms, for example? That would be
Right.
significantly better for us. I mean, but this is not how evolution works. So things can be good and bad at the same time, and it could even be detrimental for the individual at a long range. But as far as it allows you to reach reproductive age, it doesn't matter, for example. So this is another thing that I think it's also important for understanding more from an evolutionary point of view, the medical aspects of health. So the only thing I can say is that nothing is good or bad in evolution. It only depends on the context.
Right. Exactly. Once again, that's what made it so fascinating, because it made me think of things I'd never thought of before. One last question for you, Oscar, then I think we have one last question for Brian. A question is there any ratio for gene frequency that could lead to ADHD variation?
In which sense, ratio?
Well, I'm just reading a question here.
I mean, the point here is that the number of genetic variants that are associated to ADHD is very limited. Okay, so this type of GWAS studies, they require a huge amount of samples, and they potentially can have some structural problems or presence of population substructure. So usually people tend to do those GWAS with millions of people nowadays. That's what they do. In the case of ADHD, there is growing. I mean, you have to gather data first to do this type of patients, to do this, or individuals to do this type of analysis, and this is an issue because it takes time and money basically. So the number of genetic variants that have so far has been identified are quite limited, and this implies that the genetic basis of the phenotype is also very limited. With the old analysis we did, we're trying to do very kind of relaxed thresholds to include as many variants as possible. So there are a lot of noise in the results that we got, and even there we observed those trends that we were so reassuring. But the exact number of genetic variants and their contributions, the final contributions to the polygenic risk score, this is not yet done, for what I know.
Right. Yeah. Okay. Thanks. Interesting. All right. One last quick comment to Brian. I know that Evelyn in the chat said, does anyone know if that female-male ratio is the same for those who work in the genealogy or clients of sites like 23andMe or Ancestry.com? And Brian, you responded that it's not as strong for genealogy, except that it's skewed for specific cancers around breast and ovarian cancer. But Brian, I wanted to ask you if you thought about the world of genealogy and how the world of genealogy should be a perfect fit to focus on family health history, and how we can get those two worlds together. How can we get the world of genealogy, like Ancestry.com? I've actually talked to people at Ancestry.com about this. How can we get those two worlds together?
That's a great comment and a great suggestion. I've spoken with people at Ancestry, spoken with people at Family Search, spoken with people at 23andMe, and it seems like that there's some interest in it, but also some hesitancy, because it's not squarely aligned with the business models, it seems like. And there seems to be a perception that there's risk involved with getting into healthcare, and liability involved with getting into healthcare. And what we've seen in ConnectMyVariant is that entire risk can be mitigated by just being very clear about what you're doing and how you're doing it, and letting people know what they're consenting to, and then also structuring things so that health information is only available to those who really need to know it, and it can be shared by those people who know it. There's a lot you can do to lower the barrier for sharing health information without putting it out there for everyone to see.
Yeah. I'm sorry, but I do have one more question for you. This is from a presentation I saw several years ago. A gentleman is talking about he and his wife had a child, and a child was born with a rare genetic disorder, but apparently this is one that does pop up in the family every now and then. And when we talk about rare disorders, we're talking about people who are, tens of thousands of people around the world that could be affected with these. Anyway, this particular disorder was quite catastrophic for the child. And the person in the presentation says, don't we have the technology today to try to prevent that from happening? So we're talking about doing gene editing in vitro, right? Yeah. So what is your thoughts on that?
Yeah. So those are very personal questions. And I think it's very important that as researchers, as leaders in the field, that we are aware of the eugenics movement in the past, and the harms that that's caused. And so I think that we need to be very careful. I love what Oscar said about, evolution does not make value judgments. And I think that as researchers and scientists, we need to also not make value judgments about the value of a life with one gene versus the value of a life with another gene. That being said, I do think that having information can be very, very useful for parents and families, and for people who have children, and for people who are thinking of having children. And that those decisions should be made on individual levels. I've seen some people with hereditary cancer risk who say, you know what? We're living with this. We have the technology to deal with this. Somebody who has a BRCA1 mutation or a Lynch syndrome mutation can live a long and healthy life, and actually can lower their risk of cancer to below the population risk of cancer with appropriate care. And so we're just going to have kids. I've seen other people who have said, you know what, I went through this cancer, and I don't want my kids to live with this, and have done in vitro fertilization to select embryos that don't have the same cancers that they do. And I think both of those are equally valid choices for those individuals in their situations. So I think that knowledge is power, and we should encourage people to know as much as they can and to have access to the knowledge, and encourage them to educate themselves, and support their reproductive decisions, regardless of what those are.
Great, thank you. That's what I wanted to hear. Okay, we'll bring this to an end. I know that Evelyn made a comment in the chat about applying the work that she's doing around vaccine tracking, and she's working on a prototype of that, and that might involve family history, I guess, Evelyn. Yeah, so keep in contact with me about that, and that will be interesting to see how that goes, and we might have you do a presentation on that. So, all right, thank you everybody for joining. Once again, thank you, Oscar and Brian, for a great presentation. I know there were several other comments in the chat also thanking you for your presentations. So great webinar today. All right, thank you everybody. Have a good rest of your day. Bye now.
Thank you very much. Bye-bye.
Thanks, Grant. Thanks, Scott. It's really a pleasure to talk with you.